fortunate to have this group of panelists. It's led by past ABS president, Eric Horwitz, who's chairman of the Department of Radiation Oncology at Fox Chase Cancer Center. And he'll introduce his panelists in just a moment, Kevin Ginsburg and Brooke. I want to give special thanks at the beginning here to our sponsor, Varian. Our first announcement is today will be followed up by a second webinar on Wednesday, March 9th at 11 a.m. Eastern for a look at ultrasound-based HDR prostate brachytherapy, a practical guide to setting up a successful program, also led by Dr. Horwitz. An announcement about our annual meeting. The call for abstracts deadline has been extended to April 19th. We will be very excited to see everybody at the annual conference, which will be in Denver at the Gaylord Rockies Resort, really lovely resort, June 17th through 19th. We will be very happy to be back in person for this event. Please spread the word as well. ABS is looking for their class of fellows for 2022. People that have contributed to brachytherapy and radiation oncology and physics. The application can be found on the ABS website. And then finally, an announcement that ABS continues our partnership with Grand Rounds of Urology. And we're pleased to announce a new course on prostate brachytherapy. It's nearly 30 lectures online, short, concise lectures on long-term disease outcomes, toxicity, socioeconomic issues, training, and new developments, organized into 3 modules. And it is available online through americanbrachytherapy.org. And so with that, I'd like to turn this over to Dr. Horwitz. Welcome, Dr. Horwitz, and thank you so much for bringing this esteemed panel and this topic to the ABS today. I'm going to stop sharing.
All righty. So thank you very much. I'm very happy to be here and to speak for our group. So what I wanted to do was, first of all, to kind of introduce us, or have each of us introduce ourselves. The purpose of this was kind of going into, I think prostate brachytherapy is an extremely important skill. It's an important treatment option for our patients, and I can give talks. We can all give talks on all the different studies and all the data. But I sometimes think that there's questions that people have that either they're afraid to ask or they don't even know to ask about how you some of the nuts and bolts of how some of the hurdles that we have to overcome to kind of set up a successful program. And that's where the idea for this presentation came from. And I honestly cannot claim credit for it. That will go to Dr. Leachman, who will be the first person that I would like to introduce. So Brooke, if you would like to tell us briefly about yourself, or just
well, thanks everyone for joining us. My name is Brooke Leachman. I'm a graduate of Fox Chase. I've been out about 2.5 years. Really enjoyed my time there working with Dr. Horwitz. We clearly do a lot of prostate brachytherapy at that program, and I did not want to lose that skill and wanted to take it with me. So I'm currently in the 3rd largest city in Kentucky, Bowling Green. And I established our brachy program here because I said, well, hey, if I'm going to take a job there, I want brachy, and somehow I've made it happen despite the pandemic and everything. And I'll share more details about that, but we're up and running, and I'm very excited to share my experience.
Well, thank you. And Dr. Kevin Ginsburg, if you could do a brief introduction of yourself.
Absolutely. Hello, everyone. I'm Kevin Ginsburg. I'm a urologic oncology fellow at Fox Chase Cancer Center, which is how I fortunate enough to know Dr. Horwitz. I trained at Wayne State University in Detroit, which is where I got introduced to HDR brachy. 2 of the healthcare systems that I trained in had brachytherapy HDR programs. One of which started when I was a resident, and I think because the radiation oncologists there maybe had less familiarity with doing implants at the time, asked urologists to help, and given our expertise doing transperineal prostate procedures like biopsies and spacers and cryotherapy. So I think that was a natural connection that was made there. And then another program, healthcare system, had been doing it that way for 2 decades now, I think, just as a way to kind of keep urologists involved with their some of their radiation patients. So that's kind of my how I got involved and interested in brachytherapy.
Oh, thank you. And I think one of the things that hopefully will come across this afternoon, cancer care, just by definition, is multidisciplinary. And we talk about it all the time, and not just in prostate world, but in all the different cancer care. And I think that multidisciplinary care is what makes it best. Again, no matter what you are, no matter what your discipline, and again, and brachytherapy is no different. And I think it's important because sometimes we get into our silos of radiation oncologists or urologic oncologists, and I think the most successful programs are when we work with our colleagues. It's a privilege for me to work with, you know, the best surgeons in the United States. I'm totally biased towards that, and I know there'll be pushback somewhere in the country, but it's what makes it so much easier. And it's not that we all sit around roasting marshmallows together, but it really is an important component of providing the best care you can, because at the end of the day, this is what we're supposed to be doing. So what I wanted to do, so we kind of set this up as a series of questions, and we'll try to answer some. The first thing I was just going to briefly say, and I don't intentionally have any slides or anything, but just to kind of understand where we're coming from, who do we offer this treatment on? You know, which patients do we offer HDR brachytherapy? Certainly at Fox Chase, and then by extension in other places. So typically for us, there's kind of three different groups of people that I think are appropriate candidates for HDR prostate brachytherapy. So certainly it's the group who have low risk and favorable intermediate risk prostate cancer. Certainly these are the group of men who have, you know, 10 different treatment options, but if they're going to go towards brachytherapy, that's where it's HDR monotherapy. And for us, it's two fractions that we will give typically a week apart. The second group are the men who have the high-risk prostate cancers or the unfavorable intermediate risk prostate cancers, where there's compelling data, compelling studies that show that a brachy boost really makes a difference. So again, the guys who have high-risk prostate cancer, you know, high PSA, high Gleason score, high volume disease, that's a person where we'll combine IMRT with an HDR brachy boost. For us, we used to do it in two fractions. A bunch of years ago, we switched over to a single fraction. And then the third group, which is actually, I don't know, unfortunately or fortunately, growing bigger and bigger, and we have a very large practice with that, are the men who have biopsy-proven local recurrences. And this is, I think, where the group of men where things have dramatically changed over the last really couple decades, because this is something I didn't really do when I was a resident. But more and more, because there's such good care and there's so many things available, there's a whole bunch of men who got treated with external beam and have a biopsy-proven local recurrence. Those are men that we also will treat mostly with HDR monotherapy, two fractions. So they're the three group of guys that we typically will offer HDR brachytherapy to. So the next thing though is, and I can see sometimes people will be like, well, that's great. You're at a national cancer center. You have access to all these different things, but I'm not there. I don't have the same setup you have. So the first question was going to be, well, not everybody has, you know, what's your setup, because we don't all have the same setups. So I was going to say, so Dr. Leachman, can you tell us about your setup, because it's not what we have here in Philadelphia.
So I'm in a community hospital. There are certainly some challenges to setting up a new program. I clearly tried to model what I knew best from Fox Chase. So we've ended up with ultrasound-based planning, which is what we were doing at Fox Chase. I do not have the benefit of a brachy suite, so we actually shut down one of our vaults for a half a day, basically to accommodate the procedure. With ultrasound-based planning, I don't have to move the patient, so it all takes place in that particular vault, but that requires a big block of time when it comes to treating my other patients. We do general anesthesia, and thus far I've been able to get urology to come over, and they help me with needle depth and usually run a cystoscopy for me once I've placed the needles to assure that the depth is appropriate. Now, I've got several other colleagues, either above or below me, who are doing brachy after leaving Fox Chase, and their setups are different. They went to places that had an established program. So that may involve needles happening in the OR and transfer to the department. Many of my colleagues seem to be waking their patient up, and either essentially they had a spinal and just some light propofol for sedation, and then they wake up with a spinal epidural, or they've been given general and then wake up elsewhere with a PCA or an epidural. One of my colleagues is doing local nerve blocks to help with this wake up process and not being uncomfortable for the planning and treatment phase. So that's all to say that, based on, you can do CT based planning, you can do ultrasound based planning, you can start in the OR and go to the department, you can do it all in a brachy suite, which is great. You may have general anesthesia capabilities, or you may not have that kind of anesthesia support, and you have to do something else different. So there are many pieces to the puzzle that you can put together in different ways. And so lots of folks are doing lots of different things to make it work.
Kevin, can you talk about what's going to be at Wayne State? Or what
Sure.
is that Wayne State?
So currently, we do the implant together, radiation oncologists and urologists, working together in the operating room. The patient then does have an epidural. They're woken up, and then they go to down the hall to the Radiation Oncology Center for planning and further treatment. Is our current protocol.
So for us at Fox Chase, we have we're going to have 2 HDR suites momentarily, but we have one that's general anesthesia capable, and which is great, and which is, to me, ideal. We didn't always have that, though. So when I first came to Fox Chase and we started putting the program together, we also had the afterloader in a Linac vault. And what we would do is we would actually do the implant in the operating room, and we made sure we had a OR table that had little wheels, and we would literally wheel the people down the hallway, down an elevator into the radiation department. We would time it very carefully, and then wheel them into the Linac vault, treat them, and then wheel them out. Back then, we actually had ultrasound-based software. Eventually, the new department opened, and we had a place that we didn't have to move the patients. So we were fortunate that we still had the ultrasound-based software, so we didn't have to move people. But then we lost our ultrasound-based software, so then we had CT-based software. So we would do the case in the operating room, in our own operating room, but then we actually had to transfer the patient onto a bed, and we came up with a whole way to do that, move them to the CT suite, scan them, bring them back into the vault to treat. And that's what we used to do. And then about in 2015 is when we got our new ultrasound-based software. And so again, now we don't have to move people again. So the system now is excellent. It's smooth, it's easy, but it's actually evolved over time. And I didn't walk into, a general anesthesia capable HDR suite. It evolved over time. And I think that's also one of the things, as I think we all tend to be somewhat impatient people. It takes time to grow a practice and to grow a brachy practice. And, it does require patience. We don't, again, I guess speaking for myself, I don't always have it, but again, it takes time. Where we're at now in 2022 is not where we were at in 1997. But again, the more experience you have, the more things can change, and you can adapt and do things differently. So that's actually the setup, how it's changed over time at Fox Chase. I was going to say the next thing we're going to talk about, since I've now just kind of mentioned it, there's generally 2 different ways of doing treatment planning, CT or ultrasound. And actually I've done both. I don't think one is better than the other, in that what you have, that's the best one there is. And you just want to be good at doing that. There's pros and cons to the different systems. For us, being in a room we don't have to move, ultrasound works really well. I actually think CT is quite common, and it works great. You just have to come up with a system for kind of moving people around. How about the rest of you? Do you know what they'll be at? You said at Wayne State they'll be CT based?
Yeah, both the healthcare systems that I trained at in residency used CT based planning.
Mm-hmm.
And I'm currently using ultrasound, but I'm considering thinking about CT based planning, because the urology piece has been difficult. I know you started this whole thing with multidisciplinary care. We work for different health systems, unfortunately. So it's nothing about the doctors. It's more about the health systems kind of not behaving. The doctors themselves are great to work with and enthusiastic about the procedure. We just have scheduling and reimbursement issues, which is insane. So I may be switching over to CT just for some added maybe assurance about needle depth. But having done both with you, I do think they're both great, and I love not moving the patient. But we got a special bed. Orfit makes a special bed called the Zephyr, which is basically a hoverboard that we have, and it's equipped for brachy. It's got the dropout, it fits the stirrups, but you can hoverboard your patient from, you know, their special gurney to CT table and back, and not move them like we had to at Fox Chase with the crazy pillow. So that might make the moving bit easier.
Yeah, no, that works very well. Yeah, but I think it's also proof that you can do it in different ways. You just have to kind of figure out what you have, make it work. I'm going to say, I think, the part that I think is this kind of goes into, both questions that people are afraid to ask and just lessons learned over time with how we're setting up brachy programs. And we kind of broke it down into, what did we learn, if you're setting something up from scratch? What did you learn if you already are coming into something, but you want to change it over time? Working with physician colleagues, but also working with administration. I think these are all issues to kind of touch upon. And these are definitely issues that can come up that can either hinder or actually make setting up a program easy. So for me starting out, I had a very supportive chair who said, okay, do what you want. I just don't want to have to deal with it. In one way that was easy, but then when I would come and say, well, these are some of the things from an administrative point of view, did you think of this? Did you think of that? And we would learn things as we went. Usually it was okay, but we sometimes had to kind of get around things that were unexpected administrative things. And honestly, usually unexpected administrative things usually relate to cost. It was a question of, we need to do this and it's going to cost this much money and this is what our budget is. How can we get around it? Because how do we make it work? So that's something certainly that I bumped into early on. And honestly, I still an issue. It's not as much of an issue. How about you, for Brooke? How about you from an administrative point of view? What things?
I think the challenge was they had no idea what I was talking about. And sort of evaluating how many patients we would have was also very difficult because it was just a technology we didn't have any experience with. And so that's certainly been challenging. The pandemic sort of happening in the middle of all this was not helpful either. And then kind of some other administrative pieces I didn't think about up front. We're going to be like, don't forget the billing side and making sure that's all figured out before you try to go and put a patient on the table. And then the marketing, which goes back to kind of, how are they going to pay for this? You got to figure out how to market it, whether that's marketing to people or, patients, but also just to fellow physicians. How are you going to drum up excitement among, urologists and other referring providers about the capability that you offer now that no one understands?
Yeah, I mean, that's definitely an issue. Do you want us to answer some questions now as we
Yeah,
kind of go along? Or?
If you can hear me, Dr. Horwitz and Kevin, Brooke, a couple questions have come up. And first, there's a more of a general question, and it's about the process of ultrasound-based planning that I'm going to ask first, and I have a follow-up specific to being in the vault. But first, does anyone have any experience utilizing ultrasound-based planning after implanting in the OR? So I think the scenario here is going to the OR, meeting the urologist, placing the needles, getting discharged from the OR or the PACU, and then doing ultrasound-based planning, which would require reinserting the ultrasound into probably the radiation oncology suite, and then going about treatment planning at that point rather than a CT. Do you know anybody that's done that, or have you ever heard of that as a process?
So I have personally not done that, except that, so I've always kind of figured there's kind of two general ways of doing HDR. where, and again, right or wrong, I used to call, way back, we used to call it the Michigan way or the Seattle way in like the late 90s. This is where you can see how old I am, where the Michigan way was where you were just doing separate procedures. So they were just truly de novo procedures. The Seattle way was where it was a single placement of needles. Then the patient would stay in the hospital for a couple of days and you would do, say, 3 fractions. Day 1, you put the needles in the afternoon, treat, and then second day do 2 fractions. I've heard then that there's different ways where you could either replan, you would have to replan each fraction. And I've heard of it doing it both either an ultrasound way or a CT way. I haven't personally done it, but that's the one situation where I've heard of something like that.
Yeah, I don't know if Brooke or Kevin, in your experience, have you ever seen someone place the needles in the OR and then not do CT-based planning outside of the OR, but actually use the ultrasound?
I've not seen that and not aware that many of my colleagues elsewhere are doing it that way.
Yeah,
Same. I haven't either.
I think you've lost the benefit of the ultrasound-based planning at that point. If you have to take it out and move them, you've lost that benefit of they don't have to move. So then just use CT. It's better visualization, clearer visualization, easier.
well, that's a good point, Brooke, because your needle digitalization at that point is bulletproof on CT. That's really a benefit to physicists. And going back to ultrasound, you've lost the benefit of just not moving the patient, being under anesthesia for less than 2 hours, and you're already in a process of moving the patient. And if you've had that figured out, you won't have needle migration and you'll have a solid program. And like Eric said, CT or ultrasound, you could be successful either way. Here's a question. I'm sorry, please.
No, I was just gonna say, I agree completely with that. I think that if once you're moving the patient, I think you kind of lose the advantage of the ultrasound. And then to me, honestly, I think CT is probably the way to go.
So a question about just anesthesia, and this is always a big question. And this comes in the Q&A session here, and you may not see this, but in your vault, how do you use anesthesia? Is it propofol alone? Do you have a gas scavenging capability, which I don't even know what that is, but I'll let
I will tell you what that is.
Please address this question.
A scavenger line is actually where the gas that the patient exhales, it has to be vented somewhere. So like operating rooms have multiple lines. So that's what a scavenger line is. So you can assume, since I know what a scavenger line is, we have a scavenger line. So we have actually, we have a truly general anesthesia capable operating room where the patients are actually intubated. It's true general, with sedation and then intubation and paralysis. We actually didn't actually start that way. We actually did spinal. So the first almost 10 years, it was spinal with sedation. And it works great. Actually, the patient's actually a little bit more stable, because in fact, I just misspoke where they're not paralyzed, but with spinal, they're not moving. What we ran into though was it would actually take them longer, because ideally we discharge our patients. We don't keep people overnight unless there's a reason to keep them overnight. And our goal is to discharge them without a catheter. So it would take longer for their pelvis to unfreeze with the spinal. And I actually can still remember the patient. It was a relatively young guy I was treating, and he really, really didn't want spinal, and he wanted general, and we could do general. So it was just the way we had set it up. So, I deferred to the anesthesiologist to do anesthesia things. And I said, this patient would like general. They're like, okay. And he did general, and he did great, and he got out like the earliest and discharge of like any of our patients at that point. And it was because the general was, in that way, I do think was a little better, just for as far as voiding before discharge. And I still remember, he was I saw him for years and years, and then eventually we stopped because he was like, more than 10 years out. And he said to me, he's like, I always like to ask my doctors, did you learn anything from my case? And I remember in a follow-up, I'm like, yeah, actually, we changed how we do anesthesia for every single patient because of you. And he was so excited. But that's actually when we switched from spinal to general. But that's actually so our operating room has that. But
Yeah, that's
And-
great.
and-
Just a follow-up too is, what do you think about spinal anesthesia with brachytherapy, with HDR?
I mean, it's great. I mean, the patients love it. It's just, again, to comment on, like, I don't really care what the patient has as long as they're comfortable. I've done it both ways, so it doesn't matter. I do think they tend to avoid a little quicker,
Yeah.
with general. I was gonna say, Kevin, what do you think? I was gonna say, you have actually more experience than any of us as far as getting patients discharged with different anesthesias.
Again, I was lucky that one of the healthcare systems did like you said, the Seattle way, where they had a spinal anesthesia, and the implant stayed they went to CT planning. They then had one treatment. They had a PCA. They stayed overnight. They had two treatments the next day, and then so they all avoided very well because that spinal anesthesia had worn off in the 36 hours that they were in the hospital, so it wasn't an issue. So I really think it's just kind of dealer's choice to whatever fits best with the logistics of your system and what's going to work well in your workflow. Like we said, there's some logistical issues that come with delivering a general anesthetic. If you could do that safely in the vault as opposed to propofol and spinal, you may not have those issues.
Yeah, and if you don't mind me commenting as well, with ultrasound based, I think the spinal anesthesia is wasted because you really want the recovery just 2 hours later or even less. And the propofol is so light and works so well, guys really wake up so quickly anyways. With the spinal, you're going to have delayed urinary function. And even in a CT based program, you can turn the patient over in 4 hours for the single fraction. We're not keeping them overnight. I think that there is controlled data on this in the seed world that you have delayed urinary function. And I think a real light propofol, local anesthesia with Marcaine is a really good combination for guys' comfort in the CT world and avoiding the spino. But you can do it either way successfully. It's a conversation with your anesthesiologist, and that's where you're going to have a winning product for the patient. We have a couple other questions about sequencing of MRI. Do any of the panelists here use MRI in their process, whether it's ultrasound or CT?
So again, we have MR. So we actually use the MR for the volume study. So even if a patient's had imaging before they show up, we do need to document that we really know the volume size before we actually take them to the operating room to do an implant. We don't want to be surprised. So for us, we do, so we call it like an MRI volume study, just to document size in advance, because there's no pre-planning or anything. And the advantage is, and I think MR and ultrasound correlate really well together. For the patients to come in, there's no prep they need to do when they come in to sign consent and do their pre-admission testing and stuff. So it's non-invasive. It's quick because it's not a diagnostic MR. It's just it's a quick MR to kind of measure size, and we actually import it into our treatment planning system. But then the actual treatment is all ultrasound based. But the ultrasound and the MR volumes really line up very well. So that's where MR is for us. So it kind of saves them from having to do it. The only bowel prep they have to do is the days of the implant. They don't have to do it beforehand at all.
And then I know my colleague in Georgia, and I think the others are fusing their diagnostic MR with their CT-based planning just for that extra piece of information on implant day, but they're not necessarily doing an implant, MRI with the needles in place, but they're using it, as an adjunct and fusing it in a TPS.
Yeah, and I actually do CT based. I do both ultrasound and CT based, but when I do CT based, it's really MR based. I put the needles in and I do a 2 sequence, a T2 and a 3D MR that only takes 15 minutes, but I'm fortunate to have an MR right next to my OR, and not everybody has that in their setup. So we always say that this is always such a local solution. Everybody's going to have local obstacles, but I do an MR and I use an MR line marker from C4 that is FDA approved. And so you have that same ability to digitalize your needles in MR like CT or ultrasound. And and then I don't have to worry about any fusion uncertainty. But that's just another way you can go about it. Again, you can be successful without MR, but we all know how MR adds. It's one of our best tools.
I see some other questions. Or you want to?
Well, no, go for it. Go for it, Eric. There was a question about templates. What templates do you all use?
Oh God, I cannot believe I'm blanking on the vendor.
I use the same thing that you use, Eric. I don't think I know what it is.
So
They're disposable black grids.
Yeah, exactly, 17 gauge.
Really, yeah.
Yeah.
Not that exciting.
There's a lot of solutions. There's silicone-based ones that are produced. There, you have the brand-specific ones, like what just comes with the kit, whether it's Elekta or Varian. You have MR-compatible ones. Juanita Crook designed one, Dr. Martinez designed one, and that's what I tend to use. And then you can do freehand. So there's a lot of options here. If you were trained at UCLA, it's freehand is the most common technique, and their graduates that come from that. So it just depends on what you're trying to achieve. The big difference is, do you want to go to the MR after the implant or not? Because everything has to be MR compatible, conditional, approved for that. And that's, you have to go through those hoops. Everything you use at that point has to be titanium or plastic.
Yeah, so two of our residents who have graduated in the last 4 years are actually doing the freehand. And I was in contact with them, and the first few they did was a bit of a shock, and they do beautiful implants now. And they, and again, I think it's the example of, once you've done it one way, you can tweak it a little bit if the system is a little bit different, and that's okay. I like very much what I do, but it's not the only way. Again, we have a disposable plastic one, and I'm embarrassed that I'm totally blanking on the vendor, but it's it's independent of Varian and Elekta, as far as whatever they are. And I just, as soon as we disconnect, it will pop in my head.
I always say, put them all in your hands and see what you like the best. I mean, you and practice with them, and you'll figure it out. How about sequencing of hydrogel? Do you use hydrogel for your monotherapy or boost cases, and how do you sequence it?
So we offer it to everyone now. We were slow to use hydrogel. Once we embraced it, we kind of went all in. It really, really works. And again, I think this is a system we're working with our urologic colleagues. The way we set it up is our urologists are the ones who will place it. And it's some of it is literally logistics, in that we have 7 urologic oncologists, and there's only, at the main center, there's 3 of us that are the GU, brachy radiation oncologists. And they're awesome, and there's no reason not to. Sometimes we're short of space. So if our HDR suite's not being used for a case, actually, and they're short of OR space upstairs, they do it in their office, but if they need to do some OR cases with like a little light sedation for space OR, they'll actually do it. In our suite, we just let them use it. But timing of it, we do it in advance, so it is an extra procedure. So the sequence typically is, once a patient's decided and they'll get a master schedule, the hydrogel will be first, typically. And again, most of the time it's office based, and it
usually just local without any sedation. We just do it in our procedure room on the other side of this wall.
Yeah, no. So I mean, they're great space. They do a great job, and it's literally done under local. The patients that do it, we do it under sedation, are if somebody really requests it and just doesn't want it, under local, or our reirradiation, or our biopsy-proven local recurrence patients. Those people tend to be a little bit more often that will do it with sedation, because those are a little trickier. But typically, it's a week before we do the hydrogel first. A week later is when they're going to come in to do consent for the procedure. That's when they're going to do that MR volume study. And then usually a week or so after that is when their first case is. And again, they have a master schedule, and then our implants tend to be a week apart. So that's if it's for monotherapy. If it's for a boost, again, you kind of want the benefit of it for both the IMRT and for the implant. So again, hydrogel first, sim for the IMRT, get their IMRT, and then we're going to do the implant like a week or so after that. That's our sequence.
Yeah, there's a lot of flexibility that way, I believe, and it depends on who you have involved. I think there's a lot of ways to be successful, and you don't necessarily have to be held to what, the people do down the street or how you were taught. It's just doing it right. How about this question? How long, now that you're an efficient practice, you have a lot of years of experience now, Eric, how long from the time of starting the case, say the anesthesia point or the placing the Foley, to waking up the patient, how long does it take your team? What should people look for as they're starting up, say in the first 6 months, first 20 cases?
So I would say, first of all, it's not a competition as far as timing. It depends if I do it all myself or if I'm doing it with my residents. And honestly, the majority of the time it's the residents, because that's how we train everybody to do it. And that's why they can all go out and do it. And usually it takes about 2.5 hours from start to finish when it's the whole team. And we usually do two a day, 3 days a week. So we usually do 6 implants a week. When we've really gotten backed up, we'll do 3 in a day. If I'm doing it myself, with not teaching, we can be from start to finish done in an hour and a half to an hour and 45 minutes, usually.
Right. And not to take.
Starting. So I was going to say. So then, Brooke, how about for? So that I would not expect that at all when you're starting. It's you, and you should take your time.
Yeah, I think it's definitely. I had an outlier case recently that was a technical disaster, and waiting for urology has been a struggle. Not that they aren't well-intentioned, and getting anesthesia in for an afternoon case when you're not the first case today. So kind of standard sort of OR lags. I mean, so mine's more like 4 hours probably at the moment. So I'm blocking, essentially my entire afternoon and blocking the vault for that. And I hope that will improve over time as we refine everybody's role and get the timing down. But yeah, we're not at 2.5 hours.
And I love that. And Brooke, I love that because it takes what it takes, right?
Yeah.
You don't have an option but to do your best, and 2 hours, 4 hours, that's fine.
Yeah. And again, this is, I mean, despite my youthful appearance, I've done this a while now. And you do get faster over time. And also is like practice with the team, because it's not just you that's learning to do this and getting the experience. It's your, procedure nurse, it's anesthesia. It's again, working with urology. It's just, then it's just the efficiency of where you're at. Some stuff, just no matter how efficient you are, there's just downtime, turning over the room or something in between cases. And if it's almost like more pressure if you're looking at your watch, trying to get it done in a certain amount of time. So I would absolutely, to me, if I was, starting off, at least to me, you block 4 hours. And then assuming over time, you're going to get more efficient. But if you block 2 hours, you're going to head for disaster if it's it's your early cases, your first few.
Yeah. So 2 technical questions to the panel. One is, do you do a volume study? What's the purpose of it? Or do you not even consider that before the OR do it? So an ultrasound volume study like you would do for LDR. And second, how do you deal with arch interference with HDR and your HDR technique?
Okay, I'm gonna let Brooke, if you want to go first, because I keep talking, or
No, it's okay. Most of my referral pattern is high risk, so I've been doing combinations. So I'm getting my CT, my MR to plan my external beam anyway, and that's my second check on essentially volume. The urologists usually hit it pretty spot on with their volume studies when they're doing biopsies, but that's another check, and so I certainly take that into account when I'm doing my contouring. got to consider any sort of shrinkage from ADT. I recently did a case that was a time in between kind of his planning for external beam and when we actually did the implant for scheduling reasons. And I think he did experience some amount of shrinkage in between. So trying to get your volume study as close as you can to your implant, whether that's just for external beam planning or just a volume study, I think is useful.
Yeah, so no, we do not do an ultrasound volume study in advance. We're just doing that MRI because
Yeah, I mean, and I mean MRI and CT based
Yeah.
volume. I mean Fox Chase volume study.
Yeah, but, and again, to me, I do think you need to document volume before you put a person to sleep, because you know, 9 times out of 10 you won't be surprised, but you don't want to be surprised. So that's how we do it. So we never do ultrasound in advance. It's just MR. But in the operating room, I mean, the position for us, the patient's actually an extended dorsal lithotomy, which is a little bit past 90 degrees. And that's kind of rotating the pelvis. It's kind of hard to see on the computer screen, but you're kind of getting a better view of the pelvic inlet that way, as opposed to if it's just like dorsal lithotomy, you actually, what you're seeing in the opening is a little bit less. That almost by itself takes care of it. I mean, I actually think HDR is more forgiving than seeds as far as volume. So, I mean, the way I learned it, it was 20 to 60 cubic centimeters, and clearly on the boards, that's what you say. But we implant 70, not all the time, but without a problem. And we can also implant 18 and 16 and 17 without a problem. That's where it's more forgiving. So we don't. So we actually most of the time don't have that much pubic arch interference. Where we actually do, it's actually been with hydrogel, because what you're doing, depending on how good the hydrogel is, you're pushing the prostate anterior and you're almost pushing it into the, behind the pubic arch, not going into the arch. So what we've been doing is I try to angle the probe kind of going up, because it's mounted on, again, it's kind of hard to do this visually. It's mounted on the end of the table. So instead of like coming, if the perineum's here and coming this way, if you kind of come from below a little bit, just a little bit, you're actually getting under the symphysis, and we've been fine. And we actually, I'm trying to think, somebody this week was like 75-ish, but again, like, like minimal symptoms. That's why we did it. And we literally had no problem because of kind of the direction we came from.
Yeah, I think I think if you come from the seed world, you need a fixed prostate. You need to get your needles there exactly where they're supposed to be. But the HDR world, the needles, you image, you confirm them after you placed them. So you have some flexibility. You can start low and end up high. You can float the prostate real high to avoid the arch, and then you get your needles in, and then you just move it down and you can visualize them again. There's a lot of flexibility with HDR. If you come from the LDR world, it's something you have to learn. But in just going in this direction, and this, Kevin, I want to involve you in this, absolute contraindications to HDR: size, median lobe, AUA score, other issues, as a question. You just mentioned size, Eric, your upper end maybe being 70 or 80, but you'd probably take bigger if the guy had a wide pelvis and a low AUA score.
I'm actually going to default to Eric and Brooke on this one, just because as much as I enjoy caring for my patients when they undergo brachy, I don't know enough as a urologic oncologist to really counsel a patient between, to help them determine between IMRT versus HDR versus a boost. So I'll kind of default to what Eric and Brooke think is best here.
Do you want to go first? I just feel like I talk all the time, so.
You're the worldwide expert.
I know.
I feel like this is a board's question, right? I mean, so the board's answering.
So so if you're going to go by like IPSS score, AUA score, I don't have a number in my head that like, oh, if a person has this number, it can, it's okay or it's not okay, because I'm sure we all have experience on how men fill out these validated forms. They sometimes fill them out in ways that are a little unorthodox. So the number's not always the best, scale. So I wouldn't be like, oh, the AUA score is over 20, I won't implant. I kind of, I asked the patient how comfortable you are with voiding. And if the person says, I'm okay, and again, the other way to say it is, it's a weird question to ask, but in prostate world, I think it's normal. Does urination control your life? And if the person's like, no, and if they're taking an alpha blocker or not, that person's probably okay. If the person's like, I've literally tried 5 different medications over the last decade and a half, and I can't get through a dinner, or I can't get through a movie, or I can't get through a football game or a baseball game, maybe it's better, without urinating, that's a person I probably would want to avoid. So from a size point of view, that's what I would, that's kind of how I judge if it's okay or not. And I'm not sure I totally answered the question now.
Yeah, I know everybody is so aware of all my publications, but in prospectively, we looked at this in our series at Emory in nearly 500 patients and looking at EPIC CP, patient-reported quality of life, and we compared large glands versus small glands, high IPSS scores versus low. And really, you can see a little bit of a signal in the acute symptoms, but everybody comes back to baseline. And I'm very comfortable with very large glands with HDR. It's just, if you can technically get a needle there, it's a very good treatment. And the same with IPSS scores, median lobes in particular, that's where your multidisciplinary care comes in. We identify median lobes by symptoms up front. Some people do PVRs and stuff like that. There's never harm in that. But if you see a big median lobe, talk to the urologist. If it's a case where you could have a mini TERP, is a word that's been taught to me, but Kevin can say it like the most minimal amount of removal of that median lobe. Wait 3 months. That's my number. Wait 3 months and then go ahead with the definitive management. If the guy wants is really, that HDR makes the most sense to him, that's what he wants, that's what the best plan is for that person, that's a way to approach median lobes. You can implant median lobes, but you don't really necessarily need to, depending on the disease status as well.
Yeah, I mean, we would much rather, from a urology standpoint, we would much rather take care of that median lobe prior to radiation than after, just because the incidence of incontinence is much worse if you TERP someone after radiation treatment. Also, just from a surgical standpoint, sometimes when I'm talking with these patients, this may not be the thing to say at the Brachytherapy Society meeting, but that's someone that may want to consider surgery as well if they do have a lot of voiding symptoms. That's something that may get better with surgery.
No, I would agree completely. There's some people that it's just not the right thing. And this is the thing, though, that I also learned from my friends and my colleagues at Fox Chase. The bladder is actually quite forgiving, and
it is.
It's
you can do anything to it, really.
You can do right. And I used to be so afraid of, like, when I'm putting the needles in. Oh my God! If I prick the bladder and like there's any bit of blood, and the quality of the ultrasound where you're flipping between axial and sagittal, where you can see the tips up against the bladder, and again, that's why we do cystos, to make sure. Yeah, I don't want to radiate the person while the needle is in the bladder, but if you have to pull the bladder back, if you have to pull the needle back, bladder will heal. And that took me until, again, one of my good friends who literally, we've worked together now for a decade and a half, almost 2 decades. He's just like, oh, the bladder's fine, don't worry about it. And so you know who I'm talking about.
Absolutely.
But it was really a good thing to learn, because we're like, oh my God, a little bit of blood is so bad. And it's like, no, it's really okay. And also, again, it's how you prepare the patient. So if you say, like, oh yeah, don't be surprised, a day or 2 after the implant, you might void a little blood, it'll clear up, don't worry about it. Obviously, if there's a problem, tell us. And it always does. And even patients who need catheters long-term, the catheter always comes out. They can always void. And even if you have to do intermittent catheterization, it doesn't happen often, but it does happen, and especially when you do a lot of implants. And to me, if we live in fear, we're going to then limit who we can implant, and it's also going to limit their care. And I do think, I'm not a urologist, but I'm a pretty clued in radiation oncologist, and it just makes the care so much better. And I work with a bunch of really clued in urologic oncologists. They're not radiation oncologists, but they're comfortable enough with what we do, and they know what they know, and the stuff they don't know, they'll just defer to me, and vice versa. And it's just like, if you kind of explain up front, yeah, we're going to take the catheter out, you're going to be fine. But you know what? Every once in a while, someone has a catheter for a little bit. You might even have to do intermittent catheterization. I know you don't want to do it, but you will be fine. And they always are. And it makes it so much better. And the patients are okay then.
This may be a good time for just kind of to plug my personal life philosophy about why I'm interested in brachytherapy. And that is, I said earlier that, a rising tide really lifts all boats. I think if part of the issue is you're having a hard time convincing, your urology colleagues, I think you can help kind of frame to them that there really is a lot of value in helping grow a brachy program. That if we're going to be, a regional prostate cancer center of excellence, we really should be able to offer entire comprehensive care that pairs an individual treatment with a patient and vice versa. And that way, we're not painting in broad strokes of active surveillance surgery or radiation, but really are able to offer nuanced treatments to the appropriate patients when needed, much like I would support my radiation oncologists. They're phenomenal. And if they, help them grow their program, I know that they would in turn support me and my focal therapy interests and my surgical oncology program as well. And, what's good for one is kind of good for all. And I think that's a great way to potentially frame these sorts of things as you're trying to get urologists on board, whether it's to do that cysto or maybe help kind of lend some of their perineal anatomy techniques and do the implants with you. I think there's, I see tremendous value in being able to really make sure that my patient's getting the appropriate treatment that they need.
I mean, I just would agree completely.
Yeah, and Eric, we have questions. We're trying to address them and
Okay.
also kind of take a look at kind of your topics. And, we have a couple minutes to finish up. We can have some closing conversations, last thoughts.
So let me ask Brooke this, because you're closer to it than I am. What things did you run into that were unexpected? Like we could kind of anticipate, oh, this is going to be hard or not, but there's going to be something that was like not actually expected in getting your program up and running. And it's a huge accomplishment. I mean, and you're the only HDR brachy person in the entire state of Kentucky. Is that correct for prostate? Or if not, you're one of them. They're
One of the very few in the state of Kentucky. There's a propensity for LDR or just kind of no HDR. Let's do, SBRT and CyberKnife for everything here. So
what was unexpected?
I think it's funny, we're talking about all these clinical pieces as the radiation oncologists or the urologists that are really important and the nitty gritty of what we do. But if you want to start a program from scratch, you have to be the expert on everything else. And I think that was maybe the hard part is Fox Chase was such a well-oiled machine. All these other things happened without my knowledge, but suddenly I had to help everybody set up their part too. So the key is there. I know we don't have a lot of time. If you can, have a mentor program and bring your staff if you can. I brought all my staff to Fox Chase twice to see as much of the process as they can. And I'm talking the nurses and the physicists were the most important pieces there. And they continued to be a resource for us, back home as well, and would take questions and guide us. You have to walk through not only the whole procedure, and the procedure is the nurse's part, the anesthesia part, the doctor part, the physicist part. You got to walk through it, and you have to walk through the whole process from initial consult. Who's going to do the scheduling? Who's going to do the pre-certing? Do they know what codes they're going to use? Who's going to be scheduling the urologist and the anesthesia? Are all the personnel radiation safety trained? That's something we've run into time and time again. They try to send the wrong anesthesiologist who's not radiation safety trained and can't do the procedure with us. Do you have your documentation in place for the patient? Do you have your documentation in place for the electronic medical record? Do you have your billing in place? Do you have the follow-up? So there's the procedure and there's the process, and to start from scratch, you've got to be an expert in all those things. And there are lots of nuts and bolts that we're outside of the clinical pieces we're talking about here today that are really important. So practice. That is running the procedure with phantoms, gathering your whole team to do dry runs with the whole team in place, and then running the process as well with all those other people, and do that as many times as you can and make sure everyone's, thought of every little thing as best you can. There will always be surprises anyway.
Yeah, and I would say literally, like when you do these dry runs, actually use the equipment. We were talking about this the other day. Like even if it's already sterilized, open it up and use it, and then re-sterilize it, because you want the stuff in your hands.
Yeah, and you need to make sure you got the sterilization procedure all right. Right? Don't forget about those people in Central Sterile.
Yeah.
So practice, 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 and do more practice.
All right, what else are we?
Yeah, no, that was excellent. I think all this can, it can generate hours of conversation and questions, and you guys were just phenomenal today. Just for sake of time, we'll conclude it, but if it's okay, we'll push forward our emails in case there's specific questions
Absolutely.
about what was brought up today. And then you're back again in a few weeks to again address prostate HDR and other aspects of it. And so we hope everybody joins us at that time. But we're truly grateful to you, Eric and Kevin and Brooke, for bringing your experience and your story to the ABS today and to this broadcast. And I want to thank all the participants as well. The questions were excellent, and just really appreciate it. And so with
I was going to say thank you. I would like to thank Doctors Leachman and Ginsburg. And I didn't say it at the beginning, but actually very much the ABS, which is the society that is near and dear to my heart, and Varian for their support, because we can't talk about this for hours. And it is a great way to treat people. So I do want to thank everyone.
Yeah, fantastic. All right, with that, good evening, everyone, and really truly grateful for all that was said and shared today. Take care.
Thank you.
Nice
All right,
meeting
thanks.
everyone. Have a good one.
Thank you.
Yeah. Hey, Melissa, I'm just responding to a few other things here.